stream's up. Live stream is up. Should I refresh, or does that just automatic? Oh, it's 30-second delay. Yeah.
And whenever you guys are ready, I know I can call Jeff at any time, and he'll go downstairs and we can make the call whenever.
Okay. Around 9:30.
Yeah. Hi, I'm
Hi.
Emily.
I'm Dave.
Nice to meet you. So everyone's pretty excited. I know they were talking about it in rounds with all the doctors this morning. So they're pretty thrilled about it.
Oh yeah. So it's Dr. McDonald.
Dr. McDonald is doing surgery. Yes. Actually, I saw him this morning, and we didn't want to get him too worked up about it, so we just told him how many people are involved, and he was like, "Oh, okay." But he's excited, but you don't want anyone getting their nerves too. But he's so he loves it.
I know that there's around 1,200.
Well, they do it with Children of the Earth, but only in the building. They've never done it outside of the building, and I think they have 35 students. And he was telling Dr. Hildell he's expecting some stumpers because he said there's always they'll get questions that you're not anticipating. And
Right out of the blue.
yeah, he said actually the toughest question he's ever got wasn't from a resident; it was from grade 9 student.
Wow.
Yeah, it was the only question he ever had to stop and think and actually say, I don't know how to think about that. So it's exciting.
Jen was supposed to be coming in with their grade 11 or grade 12 biology class.
Oh, great.
And we did send videos out links to YouTube so that to know what to expect.
Yeah.
Dave?
I'm going to open the lines here because they're going to start rattling a lot. Our AC unit.
Dave, can we get the mics muted at the various sites? I can mute them from the bridge, but then they can't unmute it themselves, so.
Okay, we'll ask them. Okay, sorry, it's off. No, ours is on.
Yeah, we didn't know what St. John's is.
St. John's, it doesn't look like anyone's in the room. Hello, can anyone hear us?
I can force the muting, but then I can't turn it off. So
Okay.
it would be better to have each site self-muted
Okay,
rather
we will
than forcing it out.
Hi there, can anyone hear me? Hello? Hello?
It looks like they may not have audio set up yet.
Okay. I'm wondering if that's St. John's. Hello? Can anyone hear me? I don't know where that bottom feed's coming in from.
That's an iPad.
That's an iPad.
I think you said Greg's iPad. I can check the bridge. It's just in the other room, so.
Okay. Hello? Huh. Maybe they don't have their speakers on. I'm gonna send out I'll send out an email, see if I can get everyone that way.
Yeah, again, I can force the muting, but then if there is an interruption or a question that needs to happen, they won't be able to ask that themselves.
Okay.
I'll have to go through the meet now.
Yeah, I'm afraid that if I touch that laptop, it's not gonna come back.
So you have an 8,000 unit there now yourself?
I'm sorry, Andrew?
You've got an 8,000, an HD 8,000?
Yes. Yes.
Nice. How long have you had that in place?
I think around a year and a half. We borrowed yours for a bit, I believe. And then we were sold on it, and yeah, we've been using it in our classroom ever since. On average, once a month we use it. Where is... All right.
Now, when will Health Canada be connecting? Just because we upped the run to high def, 1 meg.
Okay.
And I wanted to confirm they can connect properly.
Okay. Emily, could you contact Jeff to ask him to connect?
Yeah.
Please? Thank you. We'll get him to connect.
did that all. It seems to be working.
Okay. It's working fine on mine.
Okay.
Machine.
Say that again.
I'm afraid to touch that one.
Oh, okay. Sounds good.
Okay, we have. What is that? Can you see the bottom of that screen that just came online, Andrew? Does it say Pan Am?
Yeah, it says Pan Am Clinic Conference Room.
Okay. Hi, how are you? Good, how are you? All right.
So excited.
Yeah, I think I put my mic off. I'll go get it. Perfect. Great, thanks a lot. Bye.
We're trying to figure out who's on the bottom left. They have their mic. They have their microphone on.
It's a nice ceiling shot too. Right?
It is a nice ceiling shot.
So this is Pan Am, that's it?
Pan Am Clinic's on the bottom right,
Mm-hmm.
and then we have St. John's High School on the top left.
Oh, cool.
We
They're
have-
joining too?
Yeah.
Oh, what a neat thing.
Yeah, and then Frontier School Division, the top right.
Yep.
And I don't know what's on the bottom left right now. And then we have Dave's from Frontier School Division, and he's doing a live stream of this event. So it's going to be up here. Right now we have 3 people online. So
Awesome.
And
Oh.
they'll be able to get downstairs in about 5 minutes. They're
5
just
minutes?
Wrapping up
Hi, Dave. I'm Jen.
Okay.
I think Jeff's
Okay.
wrapping, so.
Okay, good. Good.
Worried about.
Yeah, like if this goes well, we'd love to do this as much as possible next year. So
I
that's
think they're pretty excited about it. I mean, it's not a difficult thing for us to set up as long as we have a patient that is
willing.
I had an ankle repair in January and
Oh,
I'd
hi
bet-
there. Hey, Keesman.
And I would have said
Greg,
great for
Greg.
sure.
Yeah.
I wouldn't have minded at all.
Greg.
Some people are.
Okay, I know who that is now.
Interesting. Sometimes people are, I don't think
Let
I've
me,
ever
uh,
had anyone say no.
Oh, did he mute his
but
mic?
Some people have.
Andrew, can you tell?
Spotlight,
Yeah,
you
they
know,
have.
they're
Okay.
focused on you.
I have to go to the
If
other room to
anything,
see
I
it.
assumed if
Okay.
I'm being
Well, just
called,
I'm gonna.
I'm gonna
I'll
do a good job. So.
give him a call.
For the next one, we have multiple
Hey,
cameras
Greg.
and our private channel by then.
Greg.
So
Hey, how are ya?
Not bad yourself.
Password.
I'm doing well, thanks.
Oh, it's nice to see you again. Well, sort of see you here. This is there. You are.
Sorry, I just ran a lot. Lots
This-
going on.
Hey, does this take you back?
Takes me back a long time ago.
Long. It wasn't that long ago, my friend. It wasn't that long ago.
It feels like a long time ago.
Yeah.
Yeah. How are things with you?
Things are well.
The air conditioning.
I'm wearing a tie.
The air circulation.
Okay.
The air conditioning guy.
Oh, Brennan Heights is up now.
Chief right on there. He's gonna try to get somebody here shortly.
Okay.
Can't guarantee anything, but at least I asked him to turn up the air intake.
Okay. Perfect. Thank you. Thanks, Bren. So, Greg.
Yeah.
Yeah. We're just running some tests, so we need you to mute your microphone for the time being. All right. Thanks. So that's the top left, Louis Riel School Division.
Oh, okay.
Morning, James.
Morning.
How are you? So James is
I'm all right. And you?
doing well. Westland Heights, which is northern Manitoba.
Okay. This is great. I think Dr. Hildall will be here soon too.
Okay.
So and he's only the only thing he's asked. He doesn't want. I mean, this is not relevant to you guys. He doesn't want any media asking Dr. McDonald any questions because he just wants to be with the students. So if they come, they can observe, but they can't ask Dr. McDonald questions. But he said he'd go over that. So
Okay, perfect.
Yeah.
Perfect.
yeah, because then it's.
I would feel better if he said that to
Yeah.
everyone. So
yeah, no, absolutely. And I'll say it too. I'm fine with that. I know they just called me. CBC just called me. They're gonna send a team down.
Oh, good.
They're like, can we access the stream? I said, oh no, like it's protected under FIA. Like you can't access the patient. And so, but you're welcome to come down. We've got a feed. You can get footage from that. It's.
Yeah.
I said it's better anyways. You want the students in the shot. You don't want a
Definitely.
knee. Like what? People can Google a knee themselves, right? But,
Exactly.
so
20 watching.
20 on right now.
20 sites.
So 20 sites, and then we have 5 on the bridge right now. Morning.
Morning. You're on TV?
In HD.
Yeah,
see that. I can see all the wrinkles on your face.
Thank you.
That's why I'm not standing in front of that.
This is the wrong one to be looking at.
Yeah, exactly. That's the distorted one. That one puts 40 pounds on you, so that's.
Bill, this is Emily Dewar.
Hi, nice to meet you.
Good morning. And I remember Bill from, you coached at St. Vital, right?
Yeah.
Bonnie Vital, and you also, what, a couple years at South Bend?
Oh, yeah, 6 or something.
Yeah.
And your last name?
Straight. My daughter played goal for
You know what, I just
South
picked
Bend.
up on the street, so yeah, it was perfect.
Yeah, found the fun of parking there.
Yeah.
Yeah.
Yeah, I'm back at it with my 6-year-old grandson.
Are you?
Yeah, I stopped in, I think it was 2005.
Yeah.
You know, when Eduardo came in and decided he was gonna make all the changes to South Bend.
Oh, okay.
And I said, there's no way I'm gonna be a coach. He said, I'm volunteering my time. And I said, you know, he and his other guys. So when they coach, everybody's gonna walk onto the field.
So all the sites that are,
So we're connected?
yeah, we're gonna do the test call in a few minutes. Connect
Do
to
me a
Peta.
favor?
Yeah.
Connect with Jeff Helm if he has any questions for me, to email you.
Okay.
I don't have any questions.
Okay.
Do you need anything from me?
Nope.
You're okay right now? No.
Well, I wouldn't know if you needed anything.
Yeah, well, that's where we should be.
Exciting.
Yeah, so we have, right now we have 15 schools following the line feed. And then we have 5 on bridge.
The girls can vote South Bend.
How many students then?
I mean, you're
Later
getting
minimum
three
three
degrees.
will be around 1,200.
I mean, if you're going to any tournaments, you know, you've got that
Scattered
3-week
throughout
span in
the-
July, and
When it
when you're, well, put it this way, you gotta take this time period off, and you're almost guaranteed you're going to have, you're gonna end up having,
Well, you cut someone's in.
Already started adjusting through that.
everybody wants part of the show.
Yep.
Morning, guys. Good morning. How are you?
I mean, the whole idea will be, part of like,
Okay, that's fine. Now, that's the camera for our life. We actually have, we have students throughout northern Manitoba that do not have an internet connection.
Already?
So they're just gonna be observing.
Well, that's what we
our
want.
To myself before they said that.
So if that camera gets blocked, then
Yeah.
a lot of
Okay,
upset
then they
people.
said that. I said, okay, that's better.
So this one looks at,
If you need to move the chair.
where am I supposed to be standing with you?
Pardon?
Where are we?
We have more than
I
enough
think
room.
we're gonna just stand over here. And then if anyone has questions that way, cause then you can see you'll be able to see the feed.
This was,
You can see what's going on. And then the students are gonna ask questions here. Yeah, that's the microphone there. So that's the only thing, if they ask a question, then you'll just have to kind of walk over and answer it, so that everyone can hear. This is the mic.
Emily, can you hear us?
Yeah.
I saw you, I'm like,
Can you hear us?
Okay. We can.
Perfect.
Jeff?
Yes, it is. How you
No,
doing,
I
Wayne?
don't think so. We
Yeah.
can, is it?
Doing well. Where are you though?
that's all he ever said, right?
We're in the conference room.
Okay, can't see you.
Okay.
And then we parted.
Let me,
Like I, you know, I parted,
Oh, there they are.
can you see us now?
Yeah.
Okay.
So normally what happens is whoever's talking, they get that orange box around their screen.
Right.
And then that becomes the main
Oh,
video.
okay.
But what Frontier is doing, the guy up in the top right in the corner, he's the tech at Frontier. He's going to make sure that when the presentation, when the surgery begins, it will be their video taking up the entire screen.
Okay.
And then the other little screens will disappear for the time being until we have.
So are you gonna talk about the technology
Yes,
that we're?
briefly.
and I end up playing him.
Cause I just wanna talk a little bit about protocol and so Jeff is gonna go through it with him from.
No.
So, who's you?
I will see. I'm just going to talk about the technology, what our plans are, why we implemented high-def video conferencing. We're doing a lot of stuff. And
Anyways, I went to.
Okay.
So, and you'll be able to
They
see
challenged us
the
to
screen.
rip out the walls and start using real world. And that's
Yeah, students will ask
it's doing that. It makes it
So I'll introduce Jeff later.
You're gonna introduce Jeff.
How I hurt my back.
Jeff's gonna go
I
into.
wanna talk about systems
Yeah.
proposals.
Yeah, so you can go over that, and then, maybe go over that after Dave talks about the technology, and then over to Jeff, and then Jeff.
Excellent. So Louis Riel School Division, Westland Heights, St. John's High School, in the bottom right-hand corner, I'm not too sure.
Is that HBO or?
Which one's St. John's? This here? St. John's?
Yes.
Yes, it's St. John's.
We're gonna see Mog?
I don't know, maybe, maybe.
So the lady that is by herself with a white wall behind and a bookcase behind her that's just adjusting her camera, can you hear me? Yeah, there you go, you. And are you,
Her mic is.
your mic is muted, that's okay. Are you a Frontier school or? Sorry, I can't hear you. That's okay. It was more just an idle curiosity. That's okay. We've actually got all the satellite microphones muted so that this one here, there won't be any competition. But good to see you. Good to see you either way.
So right now, oh, that's just the camera.
This is the stream. This is on the internet. So if you go on the internet, this is what they're seeing.
Okay. That's pretty clean considering that, it's a camera on the TV.
Well, it's very, yeah, exactly. Well, it's a high def image. I'm just going to mute the. It's a high def image that we. Just on. Good morning, Mr. McCaskill.
So feel free to change anything, you know, like when you're out in a.
Yeah.
So you guys getting ready, are all ready to go?
Yeah, we're all ready. I believe the actual event itself, it looks like the media are setting up their cameras and everything. There's our camera and 3 others. And then we've got all the hardware set up. It's really a cool, you can't see it all, Dawn, but it's really neat. So from me, on this wall, there's a projector on the ceiling. On this wall, there's a huge screen, and it's projecting the actual stream that we're doing. And there's opportunity for people to sit all over here. And then behind me are going to be the students that are here by invitation. And they'll actually watch the procedure on a screen that's right here. And it's a 60-inch LCD screen, high resolution, high definition. And then that's what we're actually shooting with our camera, is that. You can probably, yeah, there you go. You can see Dave and our camera, and then the media cameras. So, yeah, it's pretty cool. I'm going to mute the mic.
Westland Heights all ready to go?
Yeah, and the Pan Am is on, and I think St. James is in.
I'm gonna go mute that site, Bradley.
So anyway,
We're trying to figure out who the other schools are.
yeah, Westland Heights waving. Yay, Westland! Yeah, they're waving. I can see the WLHS in the background. That's great.
Oh yeah, we'll do it like that.
Okay, I'm going to mute the mic. Can you mute the mic at my end, please, Don? Should be on the remote. There should be a remote that Andrew left there, and it's the very bottom button.
Well, that's what I'm calling about.
Perfect. Yeah, and the bottom button.
We may.
Perfect. Thank you.
Because we need to get this through this time, right? You need to tell them, see if they have anything to talk to you, so. Okay, here's everyone. Okay, you just call him and then you can, all right? Or if something changes, or if Peter's just gonna go ahead, okay?
Yeah, and you know what, it's funny, but I think, because yesterday, when I was at class, he's not been good.
Oh, nice. Is that a blue card? You got blue in that card?
In that classroom alone, and then I have.
How much does it, huh? Let's give it a try.
We don't have a handout, we're worried about screwing up your
camera to chip my camera to this too, though.
About here. So, but then that works too, because then you're in front of them. You know.
Hang on, I gotta wait. Tamara? Is that on here? 33 on here?
Yeah.
Okay. Okay, thanks.
What are you guys editing? Sorry? That's where you want to question. Okay. Peter's open to any. What I'm gonna, I'll make sure they understand. No such thing as no, just the one you did. Oh, no. So they know the Dr. Hill though. Oh, you're from Frontier. I'm the superintendent. Hi, Emily. But it was low down.
Yeah.
I didn't recognize it.
I don't be picky.
Oh,
So now we'll
Kind of
picture quality.
get awfully high rating there.
yeah.
Still subject to the content.
There we go, 37. Okay.
The gentleman who's right now, I can give it your site because the mic was open. If you can mute it locally, I'll turn off the portion of
You know what? They should probably call them down. But you know how anywhere. Yeah. Usually I didn't make
Oh, it says in the overline it should say today. So it is today. Yeah. This is at Sisler, and it's yeah. Great. Okay, we'll see you soon. Thanks. Bye-bye. Shout out to
Oh, there's no Wi-Fi in here. Very bottom left is someone's ceiling in high def. I don't know who, I think that's an iPad somewhere in this school, actually.
No, it's Louis Real School Division.
Was that Louis Rial's? Okay. So the top left is Andrew Single. He's at Frontier School Division, and he's the Division Network Administrator. And then this is the health sports Pan Am. I think this is Westland Heights down here. So they're at Lynn Lake. I think this is St. James. I could be wrong. That actually looks like it could also be Gillum. I'm not sure. And that I don't know. That's way up north. This one's certainly up north.
Can they hear us?
Not right now.
What's going to be on the
No.
feed is a surgery ACL
It's red. If that were green,
Good thing I'm
now they can hear us. Hello, Andrew. Wave hello.
throughout northern Manitoba, actually from
Oh, just
all
wave
of
hello.
Manitoba.
There you go.
And students
That's actually my office that he's sitting in.
northern Manitoba
So,
will have an opportunity to
no, I don't have my own personal. It's a test machine that we set up for these.
Well, the purpose is we have kids in real life learning experience. This is almost like a 21st century field trip. Instead of us going out to a museum, what we're doing is we're bringing a real life experience of surgery to the grade 11, grade 12 bio students. Okay, so parties that were involved, Frontier School Division, they provided their bridge, which is a dedicated video conferencing server that allows all of these parties to observe and participate. We also have other school divisions throughout Manitoba, and then we have the Pan Am telehealth Manitoba, and obviously the students of Sisler wasn't for the partners that I just mentioned, this wouldn't be possible. I'm just so excited by this opportunity where we can actually bring a live surgery into the country and I think this is the first in Manitoba and probably the first in Canada.
Question for Dave Straker, is the live stream currently muted or is it active?
Well, if you think back to, I think back to what education was like when I was in high school. It was textbooks. You're looking at pictures, you're reading about the operation. Now you get to actually ask, okay, what's going on the screen right now? What are you doing? You know, what happens if this happens in the surgery? This is a real life experience of learning from professionals. They're learning from the community, and it just enhances their learning. When's the last time you saw me this year? Oh, last year at this here? You know, after I'm done with my, no, I wanted the tweet as well. Okay. Well, maybe you can take some pictures as we go over there.
That's what I was trying to do.
Morning, Ryan. Phoenix brought down, she has a couple of iPads. Grab one. No, readable.
I know. Thank God. What school is that?
Oh, they can't see
Can you hear us over at Sisler High School?
Oh, they're from all over the place.
Tony, can you
There's
still
one
hear
from
us?
St.
I can hear
John's.
you.
There's a couple from up
Just
north.
waiting for
Mr.
Sisler. I don't know if they can hear us.
Just make sure anybody's got a cell phone, turn it off.
Dana?
Emily, can you hear us over
Yeah.
at Sisler?
Yeah, we can hear you. Can you hear us? Oh, that's embarrassing. This? This one? Press this?
Sisler's mic is currently
Can you
muted.
hear
You'll
us?
need to unmute in order to respond. Okay, that I can hear you. Okay, Emily.
Sorry, I was talking into a muted mic.
Okay, that's okay. Can you just hold for a sec? I'm gonna get them to talk from the OR, and I want to make sure you can hear from the OR.
Yeah, perfect.
Okay. Oh, Tony, can you say something?
Hi guys, can you hear me now?
Yeah.
Can we turn that on?
Okay, perfect.
Well, that's good.
Can I get them to keep talking for a moment?
Can you keep talking? Can you hear me?
Yeah, it's 30-second delay.
Yeah, Tony, can you say something else from the OR?
Sure, what do you want me to say? Did you guys watch the game last night?
Yeah. Jets win.
Yeah, the Jets are up in the series now.
Chicago, LA, big series.
You guys are off your medication.
You want me to keep talking?
Yes?
Can
Can you hear
Okay.
that?
Can you guys hear that all right?
Can you hear what he's saying? Is Can you understand? Can you keep talking?
Test, 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 test.
You can hear that? That's coming from the operating room. Sometimes it gets muffled.
Yeah, I think we're good, Jeff.
Okay, that's good. What are you guys seeing on your screen right now?
You guys.
Okay. I'm going to put up a quick wall camera shot from the OR. Can you let me know if it comes through?
Yes.
Okay. So I'm going to switch out of there again, but when we get closer to the surgery, I'll connect again.
This is the microphone for that. So the closer you are to this, the better. If you want to be off to the side when you talk?
I'll talk.
You're there? Yeah. Okay. But the audio's checking out very well.
That's a
Okay.
30-second delay.
Dana, can you hear me? Nope.
Yeah, I can hear you.
So what's happening with the patient coming into the room?
They're just doing anesthesia.
Okay, thank you.
So
You're welcome.
get them to come up right here then.
Question asks here, and then a speaker addressing the audience should be right around here somewhere, preferably right here, right next to the microphone. And then
Okay,
that
so
way
if
it'll be
somebody
nice
comes
and
up,
clear.
okay, because you want to make sure that they see.
If doctor is speaking
Okay,
to the
okay.
audience, then he should be here. Questions from the audience should either be here or they can be here as well. But normally they're going to want to look at the camera. So from the audience,
So
here.
we'll just get them to come up right here and pose a question to the camera.
Perfect.
And yeah, that's good. gentlemen, can I ask you to mute your microphones, please? Ladies and gentlemen. Okay, ladies and gentlemen, can I get you to mute your microphones, please?
Is it coming from Gillum?
Gillum? There we go. No, you didn't tell me that. It does actually have a camera, it just doesn't have a camera. Does that make sense? All right, so before we begin, I'm just going to ask everyone that's connected to the Frontier School Division Bridge to mute their microphones, please. Thank you. All right, so we're going to begin. I'm just going to say how amazing this opportunity is. This is just so fantastic. It's amazing to see all these students here, and I wish that this was an opportunity for me when I was actually in high school, because we used to have to take the little orange bus someplace else and then observe something. That was a field trip. This is actually the reverse idea of a field trip. We're bringing a real life experience to you, the students.
Good morning, everyone. My name is Mr. Leduc. On behalf of Sisler High School, I'd like to thank everyone for attending this 21st century educational opportunity, this experience. 2 years ago, we were recognized by Microsoft as being one of the most innovative schools in the world. And we went to the forum in Washington, D.C., and we were challenged at that time to change the way that we were providing our education to our students. They challenged us to tear down the walls and bring in real life experiences to you, the students. And this is an example of that. What we did is 2 years ago, we brought in this HD video conferencing capability. We've been bringing artists into the school. We've been having debates on alternative energy. We've been raising awareness of cyber bullying and cyber security, all through devices like this that you're going to be experiencing today, and connecting to the Frontier School Division Bridge. And just in case you weren't aware of this, this is a live and interactive surgery from the Pan Am Clinic. It's an ACL Reconstruction. It'll be happening over here on my right-hand side, right? We also have a whole bunch of schools throughout the province watching this event. We have a live feed up on the top right-hand side, my right, and you'll notice that it's around 30 seconds delay. So if you're trying to figure out what's going on, that's a 30-second delay. We have approximately 1,200 students throughout the province of Manitoba interacting in this event today. Not just Winnipeg School Division, but Frontier School Division, and some other northern schools. At this point, I'd like to thank everyone for getting this up and running. I'd like to thank Dr. Hildahl, Dr. McDonald, Kim and Miss Stewart from the Pan Am Clinic. I'd also like to thank our partners at the Frontier School Division for providing the bridge, which we're using to connect to. It's a secured line, and also providing the live stream so that our partner schools could watch and participate in this activity. I'd also like to thank the Winnipeg School Division and Sisler's administration team for supporting this and making sure that this does happen. Couple of things. When you are about to pose a question to the surgeons, our microphones are up here on this table, all right? What you will need to do is you're going to come up here, up to the front, stand right in front of the podium, and ask your question. I would like you to end your question with thank you. Thank you will cue the person on the other side that will tell them, okay, I'm done with my question. Wait until they respond, and then move back to your seat and allow somebody else to come up and ask a question. The microphones are extremely sensitive, so it will pick up a lot of sound in the background. So those schools that are on the bridge right now, again, I'd like to ask you to mute your microphones throughout the presentation unless you need to ask a question. The Frontier School Division also set up a chat forum for the schools that are watching the stream, and we will be supervising those questions that are coming through the chat discussion forum. At this point, I'd like to invite Dr. Hildahl to speak to the students. Thank you.
Thank you, Jamie. My name is Wayne Hildahl. I'm a physician at Pan Am. I'm also responsible for making sure things actually work and we're able to do this type of thing with surgery that you're going to watch. I'm just going to say a few words about protocol. It's live surgery. Peter McDonald is a surgeon. He's a very experienced surgeon. He teaches residents and surgeons from around the world. So he's very used to this. I want you to understand that there really is no such thing as a dumb or stupid question. All the questions, he's gone through it in the past, and he's quite willing to answer anything. The other thing about the protocol is the patient may or may not be awake, and for a lot of reasons we don't interact with the patient. Part of it's from privacy, part of it's we don't know if the anesthetist will give them any medication, so it's unfair to ask the patient to respond. So if he does say something, please don't try and engage him. So from a region's point of view, from the Winnipeg Health Region, I mean, we're just simply delighted to be able to participate in this. We think we have some pretty good technology within the region and at Pan Am. I said, but you guys here at Sisler and the Frontier School Division have taken it to a whole new level, and we're just proud to be able to participate in this, and I really hope that you enjoy what you're going to see.
I'm going to introduce Dr. Jeff Leader. He's the Director of Research. He's a kinesiologist he's an expert in ACL, which is the anterior cruciate ligament of the knee, and he'll explain something about it so that I know that you've all studied it, but he'll just go through it very, very quickly. This is a ligament that you always hear in the sports news of athletes tearing, but it happens to a lot of other patients. So without any further, I think we can connect to Dr. Leader, and then we can get going. Okay.
Yeah.
Thanks, Dr. Hilda. Can you hear me okay over there?
Yeah.
Okay. So if I get distracted here and there, it's because it's like people talking into both ears. I can hear the OR on one side and I can hear your side on the other side, and BlackBerry making sure cameras are connected and everything. So technology is a wonderful thing, and sometimes it can get a little bit overwhelming. So we'll make sure everything sort of runs smoothly here. As Dr. Hildahl sort of spoke to, anterior cruciate ligament injuries. The anterior cruciate ligament is a ligament in your knee joint, and basically this is a model of a knee. And the first thing a surgeon usually does is they're going to orient which leg it is, whether it's the left or right. And these are actually models that we use up in our lab for surgeons to train with. So when a surgeon's going to start the surgery, this is what they see from the outside. And there's just going to be little poke holes that they make in the skin so that they can get into the knee joint with a camera. We can strip all that away in our plastic models, but we can't actually obviously do that in the OR. And when you open it all up, this is your femur or your thigh bone, and over here is your tibia. These two sort of spongy structures that you're going to see, that's going to be your meniscus. And often meniscus are actually torn when you tear an ACL as well. When you flex your knee, you can get in closer, and that's where you'll see sort of the anterior cruciate ligament. The main purpose of the anterior cruciate ligament, it prevents your tibia or your shin bone from sliding forward on your femur. And having had an ACL rupture myself, I can tell you that once that's ruptured, you feel quite a bit of laxity in your knee. You feel your tibia start to slide forward on your femur. And you also feel some rotation as well of your tibia on your femur. So that's why the indication is usually to go do surgery on that knee. Not everybody needs their anterior cruciate ligament fixed, although when you're talking about athletes, athletes do get theirs.
The bed caught on the stack.
Today we're going to be using an allograft as opposed to an autograft. So the difference there is auto means from yourself, and usually what you do is you take the surgeon's going to take the semitendinosus and gracilis tendons, which are, if you feel in the back of your knee, those are two cord-like structures that are easy for the surgeon to access. Today we're going to be using an allograft, which means that the tendon actually comes from an individual that was deceased, and they make sure that it's a young individual with good tissue, and they're going to be using the tibialis anterior, and if you flex your foot up, you can actually feel a cord-like structure at the front of your ankle, and that's the tibialis anterior that they're going to be using. I could go on for this for quite some time, but it looks like we're ready to go in the operating room. So what I'm going to do is I'm going to connect you to the operating room and introduce you to Dr. McDonald. And then at that time, if you have any questions, those questions I'll hear them in the conference room, and we'll relay them on to Dr. McDonald. So can you see inside the knee joint right now?
Yes, we can.
Over at Sisler?
Yes, we can.
Emily, are you there?
Yeah, sorry, yes, we can. We just muted our mic for a minute. Yes, we can see it.
Okay, that's fine. Okay. Dr. McDonald, can you hear us?
Hi, Jeff.
How are you?
Good, how are you?
Good. So right now we've just connected Sisler High School and the other high schools that are connected to their bridge network, and they're seeing inside the knee joint. So right now I'll turn it over to you a little bit, and if they have questions, I'll relay them on to you.
East bullseye. Okay, so welcome everybody. Surgery is a team effort, so we got a great team here this morning. Dr. Kaplani's doing the anesthesia. First, we have a patient. We couldn't do it without the patient. Has cooperated with us doing this live demo. My assistant, Scott Hughes, is a orthopedic fellow, is on the back table preparing the allograft tendon. I heard Jeff talk about the definition of allograft, which means it's donated tissue from somebody who's deceased, just like a donated kidney or a heart. And then we have good nursing help too. Mike and Eric are helping us out that way. One of the nurses is called a circulating nurse. He's running around and he's not sterile. And the other nurse, Mike, is sterile. He's all gowned up. And we got Tony on audiovisual. So right now, not sure, Jeff, can you see the graft prep table, or can you just see?
Yeah, we can see, we're looking from the wall camera, so I can see Scott preparing the graft.
Okay. Is that camera working?
Yeah, the light camera is a little blurry, so our best view is kind of from a little bit further outside.
Okay, yeah, so I'm just going to take the scope out and just go over and explain what Scott's doing. So you got the wall camera. So this is the tendon. It's actually a foot tendon called tibialis posterior, and you can see it's a fairly thick tendon. And Scott is sewing it up at either end so we can pull on it. And then we're going to hook it up to a button device. So as Jeff mentioned, this individual has a torn ACL, and we have to replicate it by putting this tendon in, and we'll double it over. So it's about 1 centimeter in diameter once it's doubled over. And we're going to drill a couple holes and put it into the knee to replicate the function of the ACL. So you can see it is a robust tendon. It's from actually the back of the foot right behind the ankle, and it actually normally would work on to push your ankle down. So that's what the tibialis posterior tendon does. But in this case, of course, we're turning it into a knee ligament. If we go back to the knee here, you guys see the knee from above?
Yeah.
I'm just going to show you the abnormality in the knee. I'm not sure if you can see on the outside shot, but this knee is loose because there's torn ACL, and you can punk it out of joint, right? You see that?
Yes.
So that's called a pivot shift test. So this guy, I'll use his first name, Dave. I won't use his last name, but he tore his, he's 56 years old, and he tore his ACL playing basketball. But he's pretty avid in squash and badminton and other sports, and soccer, so he wants his knee fixed so he can go back to sports. The ACL is a ligament that you can get by without for everyday activities, but it's going to bug you if you do pivoting sports, so that's why, in this case, we've chosen to fix it for Dave. Are there any questions so far? So,
we do have one question.
Yes.
Okay, so in terms of the method that you're using from the deceased patient, what methods would you do in order to prevent infections to be passed on to the patient receiving the operation, if there's any diseases?
That's a very good question, actually. Anytime tissue is taken, doesn't matter whether it's heart, lungs, kidneys, or tendons, patients totally screened so they don't have any, to make sure they don't have any diseases that they might pass on to the patient. And then there's a cleansing process that the tendon undergoes to make sure it's, even if there was something passed on, that would be killed in the process of cleaning it up.
Okay, thank you.
So right now, can you see the scope shot?
Yes.
Okay, so we're in the knee and we're looking, and this is where the ACL is supposed to be, right here, and there's a few fibers of tissue left, but it's fairly loose and not doing the job. So that tendon has torn that ligament has torn and it's attempted to heal, but it's healed in kind of a loose, disorganized blob of tissue. So we're going to replace it with something which works a little better. And then, so that's the center of the knee where the anterior cruciate is supposed to be. There's another ligament behind there that you can't see very well. It's the posterior cruciate. So the two crossing ligaments in the middle of the knee. And then we're looking on the inside of the knee. This is cartilage surface on the end of your thigh bone or the femur. And on the bottom is the cartilage surface on the tibia or the lower leg bone. There's the tibia surface and there's the femur surface. And you can see it's pretty rough there. That's some wear and tear. We find people who tear their ACLs tend to get wear and tear because their knee is subject to repetitive trauma episodes or injury episodes. It's more apt for the knee to wear out faster, even after we fix the ligament. And this is called your meniscus. So you may read on TV or read in the paper, see on TV, athletes have torn their cartilage. That's what they tear right there. That's the medial meniscus or the inside cartilage of the knee. And as we move the knee into a different position, you can see there's a fairly focal area of pretty significant wear where that looks like somebody took a bite out of this area. So that's a little concerning, and we're going to poke holes in that area just to stimulate healing, because normally once cartilage is damaged like that, it won't heal itself unless we do something to stimulate healing. And back here, the back of the meniscus, you can see actually that he actually has the torn meniscus right back there. So I don't know if you can appreciate that, but that has to be addressed too, because that can get caught in the knee and cause the patient to have pain and locking episodes. And of course, any questions on that part?
Are you in the medial compartment or lateral right now?
Yeah, this is a medial, sorry.
Okay.
So this is a shaver. It's like a vacuum cleaner or a Pac-Man. You can see when I turn it on, there's blades that rotate and it sucks loose pieces out.
So are you just going to clean that up, or do you have to repair it at all, Dr. McDonald?
We're just going to be cleaning that up because meniscus doesn't have very good blood supply except for way out close to the attachment to the rest of the knee. So that meniscus, if we did put stitches in it, it wouldn't heal. So this is where the blood supply is way out here. If you had a tear way out here, see where it turns a little bit red, then you could put stitches in it, but this tear would not work to heal. So I've taken away the loose flap, and that's all. We try and preserve as much of this meniscus as possible because it is a shock absorber, and it's important to have in the knee to prevent further wear and tear. Get a curette. Small one.
So in terms of the process for the operation with the microfracture or poking holes, are you going to do that before or after the ACL reconstruction?
I'm doing it right now. So you can see this curette here. This is a big spoon, and that actually looks big, but it's only a couple of millimeters wide, really. So everything's really magnified. If we put that probe back in, it's only 5 millimeters wide, so everything looks really bad here, but it's not that bad when you think about it, because that's only 5 millimeters by 5 millimeters. Try it again.
At this point, is there any questions from the school?
Yeah, that'd be fine. So this is the bone underneath. So you can see how thick the cartilage is. It's about 3 or 4 millimeters thick in this part of the knee. And I'm just kind of scraping the bone, almost like a dentist would scrape your tooth, only the patient doesn't feel this. And I'm going to poke some holes to get the 45-degree microfracture roll. So this is a sharp device. We call it an all AWL. And we're just poking some holes to stimulate healing. Kind of like, I don't know if you guys have ever had your lawn aerated. That's what we're doing, same thing. Good. There you go. Good.
And Dr. McDonald, is there a certain pattern that you want when you're doing the microfracture, or does it make a difference?
Yeah, you want to put the holes a couple millimeters apart, and you want them ideally around the just where the bone meets the cartilage, so that there's some new cartilage forming at the junction. Now that forms, if you go back in 6 months, you see called fibrocartilage or scar cartilage forms in there, but it's not normal cartilage. It's not as resilient, but it's better than just leaving a hole like that. So, but it is amazing the body's abilities to regenerate. So I'll just show you the other side. The lateral side is actually pretty good. There's no tear. There's the lateral meniscus, the lateral shock absorbing disc. It looks fine. And you see the lateral surface looks good as we move the knee through flexion and extension. You see all this stuff in here. It looks like seaweed. Probably think you're looking at Jacques Cousteau or something, but this is synovium, or the lining of the joint. And that's a very important normal structure that secretes lubricant fluid for the knee. And then I'm just going to show you the kneecap here. And we just directed the scope under the kneecap or the patella. You can see it on top. I'm moving it around. And there's a minor wear and tear there, but nothing too bad. And that's where the kneecap rubs against the thigh bone there, and that looks pretty good as well. So,
how long ago did he rupture his ACL?
Dave, how long ago was it? Dave asleep? So he heard playing soccer in 2004, so it's been a while.
Okay.
And then I think he re-injured it recently playing basketball.
And those are pretty two common sports for that type of injury, correct?
It is, yeah. Like any sports where you're doing a lot of pivoting. We find that girls playing basketball or soccer is a deadly combination. There's really higher incidence than you would see in boys for tearing the ACL. So there's girls in the audience who have torn their ACL. You're not alone. There's lots of them. So I'm using the shaver again to clean up the old ligament that's tried to heal itself. And now you can see the PCL right back there, the posterior cruciate ligament. I'm just removing whatever's left of the ACL. And that's where we're going to drill through one spot that's on the tibia. And the other spot we're going to drill through right here is on the femur. So that'll be the two tunnels that we use to put the new tendon in to make a new ACL. All right.
And Dr. McDonald, how do you decide whether you use an autograft or an allograft?
That's a good question as well. I was going to actually explain that. Dave is 56, so normally we're doing this on people who are, most common is in their 20s and 30s, occasionally some high school kids. But because he's at the older end of the spectrum for doing this operation, we wanted to make it as easy as possible for him. And so because we don't have to take one of his own tendons, it's a little easier for him to tolerate the operation. Seems to work better at this stage of life. Okay, so this is a little guide that I put in, and you see in the middle there's a drill. And on outside shot, can you see that Scott has a drill? It's like one you get at Canadian Tire with a wire on it. And you're into 10. So we're going to drill a hole. And at this point, Mike's holding the knee. We need to flex it up so it comes out in the right spot. Okay, perfect. And you're going to see the wire actually come out the outside of the thigh right there. So that's kind of gross. Right there. You guys see that?
Yeah.
So that's pretty well where we want it to be. And then that's just a guide wire. So we need now to drill the actual hole. And 5.0. An 8. Okay. Do the 5.0 first. I got this good. So you can see the scope shot. We're going to put it's called a reamer. So we do 2 reamers, one small one and one big one, right over top of the wire.
Okay.
1,200 kids. Sisler High School.
And how big is that tunnel that you're making?
This one is a smaller one. It's called, it's a 5 millimeter wide, so not that big. And then the second one is going to be like 8.5, so it's a little bit bigger.
Okay.
So this one goes all the way through, and then the second one goes part way through. Okay, good. Okay, so you can see the hole there that's around that wire?
Yes.
How has the process...
It looks like we have a question from Sisler, so go ahead.
How has the process of an ACL reconstruction changed over the year? Thank you.
It's a good question. Like I trained about 20 years ago, and it was a little bit different. I'd say like if you go back even longer, 30, 35 years ago, probably this operation wasn't that commonly done, but now it's super common. We just get better instruments, better techniques, and just kind of make it more and more like the real ligament. We're still not there yet, but it's getting better all the time. That's a good question.
And has the tendons that you use to reconstruct the ligament changed?
That's always a bit of an area of controversy. Jeff knows as much about that I do, but we use a lot of hamstrings, but as you know, this time we're using allograft, but some people use different parts like the tendon that connects to the kneecap or the tendon of the quads. It's controversial, and different surgeons use different tendons. We need the wire back. Dr. Leaders had an ACL. I'm tell you about his experience.
That I'm part female.
I love that joke. She walks like a girl now.
I'm going to have to get you to switch that out, I think.
So it's 34. Yeah, so those like high 20s. Yeah. Okay, so this is the second reamer. 5, Mike. Okay, so we see there's measurements on the reamer, so we want to go in, we have to go in actually precisely the right measurement. Hold on, I don't think you're far enough. Wait. All right. Touch more. Okay. Okay. Stop. Okay, dilator.
So Dr. McDonald, how do you decide how big you make the tunnel? Is it dependent on the size of the graft?
Yeah, so the graft was measured in the back table. I guess before you, or we didn't catch that on TV, but we measured so it fits nicely in the tunnel.
Okay, and I think we have another question here from the high school.
I was just wondering, why does the ACL need to be reconstructed and not repaired? Thank you.
So just to repeat the question, I believe it was, why does the ACL need to be reconstructed? Is that correct?
Yes, and not repaired.
Yeah, so first of all, we don't do it every single time. If somebody doesn't play sports or they're a bit of a couch potato, we would probably consider not doing it. Somebody's active in sports, we just find that they need their ACL to function. Otherwise, they tend to get. You turn the pump up to 90. They tend to get more damage to their knee every time they play sports because, as I showed you on that little exam, the knee pops out of joint easily. So every time it does that, it does a little more damage to the knee. So that's why we do it in athletic individuals.
Thank you.
Okay, was there another part to that question, or was okay?
Well,
I think.
Go ahead.
Well, as opposed to it being repaired, why can't it just be repaired? Not why does it have to be completely?
Oh, okay. Yes.
Oh, you mean just stitch it up?
Yes.
Yeah, it doesn't heal very well, unfortunately. It's a defect of our biology. Certain ligaments heal quite nicely, like the medial collateral, the ligament that runs along the inside of the knee, heals really nice just without surgery. It's got a better healing potential. The ACL doesn't heal very well.
And a lot of that probably has to do with the blood supply too. So if there's blood supply going to areas, they usually heal a lot better.
Yeah, so we're looking up the tunnel now, and there's a little bit of debris, but you can see that the sutures, we passed the suture up the tunnel, and then you can see that the small tunnel's in the center, and the larger tunnel is around the periphery, and so we have a button. We want to sneak that button through that small tunnel, and so it locks on the outside of the femur bone. Not sure how clearly you can see that.
We can see that nicely.
I'll put it down first, and then we can stop it. Okay. Okay, so now we're gonna, that's one hole down. Now we got to do the other hole, the tibia hole.
I'm going to go to an outside shot again.
Okay, so I'm just cleaning up the area where we're going to drill. And scalpel. Okay, and then, so this is a guide that's going into the knee, and then we're going to straighten the knee out, if you don't mind. And now we're going to drill the other hole. Okay. So I'm making a little incision so we can get through the skin down to the bone where we're going to drill. Anybody queasy out there? A little bit of blood.
Everybody seems to be okay over there.
No pizza there today?
Not yet.
Okay, so this is a jig that just allows us to drill in the right spot. Now, okay, so have you looked through the scope? I'm not sure if you can see through the scope now.
Yes, we're on the scope now.
Yeah, you can see nicely the through, and
oh yeah,
we're gonna put the reamer in over top of that wire, and so we'll have our tibia hole, and maybe a quick outside shot to show that Scott's just reaming the tibia side.
We see a little fluid coming out there. Is that water?
Yes, if that's water. So yeah, good point. There's water circulating throughout the knee. We pump it throughout the knee. You may wonder why it's not bleeding very much. We have a tourniquet on, which squeezes the thigh so blood can't get through. So that's good. It makes it nice and clean. Makes it easy for us to see. And the constant water circulating also cuts down the risk of infection.
Okay. So we're looking back in the knee joint again.
Crochet hook, please, Mike. I'm just grabbing onto that suture now. Change the suture. Yeah. Yeah.
So you sutured the end of the graft so you can pull it through, is that correct?
Yeah, so I'm going to show you in a second here. This suture is a lead suture. And now I've grabbed it. If you look through the scope, it's now going through both the tibia hole and the femur hole.
Okay.
So it's that's the path where our tendon is going to follow. And so I'm going to take the scope out for a second. You can go to an outside shot. Okay.
Okay.
And so here's the suture that's coming out, and it's going all the way over here, out through the both tunnels. And so this is the graft. See, it's double over, and it's got this button on it. So that button goes out and hooks on the outside of the femur bone, and we'll put a little mark to show where the femur tunnel is. All this is going to be within the tunnel, and it's going to go up to that mark. And then where my other hand is where that part's going to be in the tibia bone. So we're going to put the button here to secure it on one side and a screw to secure it on the other side where these stitches are.
Okay. Are those, are the button and the screw ever an issue in terms of loosening or complications?
Well, anything's possible, but most time works out pretty well. Okay, so now you can see the graft is about to go into the tibia tunnel. And if I just straighten the knee, you can see where it's going. Scott's going to pull on the one end, and I've got the other end.
Okay.
Hello?
So this is going inside right now.
Yeah.
These are questions coming
Okay,
in from a different school.
Okay.
Someone asked if there's a death risk in this kind of surgery.
Sorry, I didn't catch that question.
The question was whether the risk of death in this surgery.
Very small. In the United States, every time you have an operation, they tell you that because the lawyers are so active down there, but we don't normally go into that because it's people like 1 in 10,000 or something like that here.
Okay.
And also they asked if it's an orthopedic surgery.
Did you hear that? Well, the question was whether they asked whether this was considered an orthopedic surgery.
This operation, yeah, is called arthroscopic, but it's within orthopedic surgery. Good. Okay, now, so it's a bit tricky what Scott's doing right now.
There's another question.
And, okay.
Someone asked if what is the average recovery time?
Yeah, that's recovery time. We aim for about 6 months before you can return to sports. Take it easy, take it easy.
Okay, thank you.
So it's a 6-month period. Just because this tendon's a dead piece of tendon, and it takes a while to grow in, and also takes a while for the patient to get the strength back.
And so now you're pulling the graft through the femur?
Yeah. So if you can go to the inside shot, you can see really nice, let me do this. Yeah. Okay. You can see a really nice picture of the new ACL on the scope view.
Looks very good.
Yeah. So that's a beautiful looking tendon. Yeah. Okay. Now we're presuming the button is slipped. I'm just pulling back just to see. It feels like it's a firm endpoint, and it feels like it's locked on that piece of bone on the outside of the femur. So Scott did a good job. It looks like it's going to be locked there. So now we just have to put a screw on the other side where my finger is down here.
Okay.
That goes into the tunnel, and it's called an interference screw, and that, yeah, thanks. The interference screw just goes into the tunnel and just basically jams its way in and jams the tunnel or tendon within the tunnel so it can't move anywhere. So, for example, like the tunnel is 8.5 millimeters wide, and the screw we put in is 10, so that tendon will be really squished within the tunnel. And in about 6 weeks, that'll heal inside the tunnel, so it'll be no longer a factor. And the screw we put in actually incorporates into bone over about 5 years.
Okay. We have another question from the high school.
What therapies will the patient have to undergo after the surgery?
So for the first 3 weeks, the patient's on crutches and putting a little bit of weight on the leg and doing a little bit of range of motion exercises. And then after that, we send them to a physiotherapist usually if that's available. And they do, they get rid of their crutches and start strengthening, doing more advanced range of motion exercises. That's why it takes about 6 months is stiff and sore, and muscles atrophy, and so it just takes a while to get everything working again.
I understand from over there, there's quite a few football fans, so I think the question was related to Adrian Peterson and how quickly he came back and how successful his year is. Is that something that's fairly common, or is that a bit out of the norm?
Yeah, if I'm not mistaken, I think he's about 8 months from surgery to when he played, which would be what you would expect, but the fact that he played so well and almost set a record last year is amazing, actually, coming off that surgery. So yeah, he's pretty well exceptional, because people come back, but when they've shown for the first year, they're not quite comfortable with their knee, and it really takes, if you want somebody to return completely to as good as they're going to get, probably you're looking at a year.
Okay.
Come back and play sports, but you're not going to be at your highest level for about a year.
Okay.
Unless you're Adrian Peterson.
There another question there?
Are there those who can't have the surgery, the diabetic, the previously diseased, or anything along those lines? Thank you.
Jeff, can you repeat that question?
Yeah, the question was if there's factors that would exclude individuals from having the surgery, such as maybe diabetes or other diseases going on?
Yeah, you can put the turkey down. Yeah, there would be. I'll just show the kids first. There are some factors, like if you had poor circulation, or like diabetes can lead to poor circulation. So every case is a little bit different, but generally somebody who has a lot of medical problems is not playing much sports anyway, so they may not need the operation.
Okay.
So you can just see the end result here. We've pulled these sutures out over here, and this is the excess tendon right here, and we're going to cut that off because we don't need it. Scott's put a nice screw in here, and it's pretty solid. It's all the way into the tunnel. And remember, before I could wiggle the knee out, now when I flex it, it won't go anymore. Like it won't pop out of joint. So and this is called the Lockman test, and that's pretty well rock solid. So worked out good.
Looks very good.
And so we just cut the excess off here. And that's it. We just have to stitch up these wounds, and that's all there is. Sure. Patient has a question.
Okay, go ahead.
Will the patient be able to participate in all?
Patient's asking how do we know the screw doesn't damage the tendon, and the screw is it's got threads on it, but they're pretty dull threads, so they usually don't damage the tendon itself. But if you were to take it out and put it in several times, it would. So.
Okay. I think we have another question here from the school.
Will the patient be able to participate in all his sport activities after the surgery?
Patient will be able to put partial weight upon, but we'll need crutches for the first 3 weeks.
Thank you.
And then after that, are they okay to go back to all sports that they played before?
Is that what the question was? Sorry.
Yeah, no, that's okay.
Yeah, the patient can go back to any sport, hopefully, if it all works well. If it all works out well.
Go ahead with another question.
Actually, I have a few questions from another school. The first one is, what are the odds of getting an infection from this?
That's another very good question. It's about 1%, so 1 in 100 get an infection. And that can be sometimes difficult to treat because you have material in the knee that doesn't have a blood supply, like the tendon and the screw and the button. So we try and, in that situation, give antibiotics and wash the knee out with the scope. But sometimes if the infection is bad, we have to take the tendon, the screw, and the button out. So in severe cases, it can be quite a nuisance, and the patient has to undergo more procedures.
may I ask another question?
Sure.
How does the new ACL attach to the bone, and do they need to take anti-rejection drugs?
We normally give what we call prophylactic or just in case antibiotics just before the operation, just so there's some antibiotics floating around in the bloodstream, and to hopefully kill any bacteria that might be trying to decide whether they want to go in the knee. And what was the other part of the question?
How the graft is connected to the bone on each side.
Yeah, it tends to grow in. The sides of those tunnels are rough, very vascular, or good blood supply areas of bone. So it tends to grow into the tendon probably within about 6 weeks. So that's why we were really cautious the first 6 weeks with the crutches and everything, and then after that we can be a little more aggressive with exercises.
Okay. Did you have one more question there?
Yeah. Are there any potential complications after this surgery for the patient?
Yeah, I guess we talked about infection already. You can get a blood clot in your leg where the blood in the calf pools and forms a clot, and that potentially can break off and go to the lung, and that's not a very good thing because that can make the patient very sick. So we put the patient on aspirin usually for a few weeks, and also we monitor them to make sure they don't have signs of a blood clot in their leg. Other complications, just about 6 to 10% of the time, the graft that we put in can rupture again. So may have to do this a second time, usually when they go back to some sort of sport. And then the odd patient will get stiff too for a while. That requires treatment. But I'd say 90% of people are pretty happy and do quite well.
Okay, thank you.
Excellent. Well, it looks pretty much like you're wrapping everything up there.
Great. I hope you guys learned something out of that.
Thanks very much, Dr. McDonald. We really appreciate it.
Okay, thanks.
You're getting a round of applause. I don't know if you can hear it.
Thanks.
Hello?
Hello?
I have another question. So
okay.
In terms of re-injury, what are the odds of re-injuring? And what methods, like I know they do physiotherapy, but like what are the preventative methods or measures taken?
So the re-rupture rate is about 6%. So 6 out of 100 have a chance of rupturing their ACL again. And there are some specific, in addition to physiotherapy, there are some specific ACL preventative programs that are out there. And they focus a lot on training, not only in strengthening the knee joint, but also going up to your core. They talk about in terms of gluteus medius, etc. So it's more of a total body program. And they also teach jumping, etc. Proper jumping techniques.
Hello?
Hello?
What type of anesthesia do you use?
For this patient, they just used a spinal. So the patient was still awake, but they couldn't feel what was going on in their leg. So they were, during the surgery, they were asking Dr. McDonald a few questions while he was doing the surgery.
Thank you.
You're welcome.
Hello. What preparation are required of the patient prior to the surgery? Thank you.
Could you repeat that, sorry?
What preparation are required of the patient prior to the surgery?
Yeah, prior to the surgery, I mean, if they can, we ask them that they sort of be as active as possible, but not do risky activities. As well, on the day of surgery, they're required to bring a brace and also a cooling unit that they'll put on their leg after surgery to kind of keep the swelling down and get some sort of pain control.
Hi. For the graft, can any tendon be used, and will it eventually mend into the tissues of the patient when it is in?
Yeah, that's a good question. So actually at the beginning I was talking about the tibialis anterior, which they do use sometimes, but for this surgery they actually use the tibialis posterior as an allograft. So the most common allograft tissues are going to be, they'll use Achilles tendon, which is at the back of your heel. They can also use tibialis anterior or tibialis posterior. If they're doing an autograft, they can use the hamstrings tendons, or they can also use the quadricep tendon, which is the tendon that's right below your kneecap and inserts on your shin bone. And all of those, if your second question was, those start to incorporate into the bone from about 3 to 5 months. So that's kind of the time where with the patient they feel better and they feel like they can do a lot more activity, but you actually try to hold them back a little bit because you're waiting for the tissues to incorporate.
Thank you.
You're welcome. So just a more general question, how did everything come through on that end?
Great.
All right, so ladies and gentlemen, this is an opportunity for you to ask questions. If you have any other questions, please come forward right now. Oh, do we have some online? Hold on. So we do have a few online. If you're very active, how can you prevent injuring it in the first place?
Well, there's a lot of programs that have started now specifically for females because they are 6 to 8 times more likely to rupture their ACL. And a lot of those are incorporated right into now soccer practices or basketball practices. And they talk about proper landing techniques and also overall strength, focusing on the core as well as some of the gluteus muscles that control your femur and your thigh when you're doing jumping and cutting activities. So there's a lot of research going into that right now, trying to determine how effective those programs are. The first sweep of the data seems like they're helping and reducing some of the injuries.
Anyone else?
What kind of exercises do you?
Oh, I sort of, I didn't hear that first question.
What kind of exercises would you have to do? And how frequently would you have to do them?
Sheila, I'll ask you that one specifically. What are the, let's say after the first couple weeks, what are the exercises they'll mostly do? Okay. So initially they'll start with exercises where you're contracting your quadriceps and your hamstrings muscles at the same time. And then it kind of progresses from there. I'm just going to provide Sheila with a mic so you can hear her over there.
Hi, I'm a physiotherapist and I've treated some patients that have had this surgery. So initially the goal is to just get your leg to straighten all the way and eventually bend all the way. But then once you've healed a little bit and get some of your movement back, then we work on getting strength back by doing, like Jeff said, squats or lunges, things that are where both the muscles in the front and the back of your thigh contract at the same time to keep the knee nice and stable. And then eventually we progress to doing some balance and things on wobble boards and and one-legged things so that you get back your balance. And eventually we start doing jogging and jump training, both taking off and landing, to make sure that you try and land with your knee in line with your foot, and cutting exercises, and you can progress to exercises specific to your sport. So if it's a cutting sport or a jumping sport, then we would focus on that, and you'd return to real serious training by 6 months.
Could you hear that okay over there? Yes, good. Thanks, Sheila.
So any other questions in here? Okay, so
On behalf of Sisler High School, I'd just like to thank Frontier School Divisions, Dr. McDonald, Dr. Hildahl, Pan Am Clinic, and we'd like to thank you for the opportunity that you've given us. And on behalf of Sisler High School, we'd like to present the Dr. Hildahl. Present Dr. Hildahl with the sweater representing Sisler High School and giving us this opportunity to experience a live surgery. So thank you so much. Thank you.
I'm going to wear this with pride every time I go fishing. Hopefully it brings me luck.
We actually expect you to wear it at the clinic this afternoon.
I will.
My question for you guys is, how did you guys enjoy this experience? And what did you guys think about it, having this live video stream and experiencing the surgery and experiencing how everyday doctors do their stuff, right, do the surgeries?
I'd like to thank the students for coming out and participating today. Thank you very much. Give yourself a round of applause, please.
Add to that, I mean, your questions were great. I think started slow, but then you made Peter work, and that's what I wanted to see. So thank you for your question.
So that's going to conclude our presentation this morning, and hopefully we'll have many more of these in the upcoming year. So thank you very much, everyone.